very grateful to be here. I love doing this talk every year, but I also want to say I hate long rooms like this. So if I turn my head or for some reason people can't hear, please raise your hand. Say something. I rather go over many fewer slides really well and answer questions, so interrupt if something isn't clear or confusing, because that's still a better end result than me just running through 60 slides and everyone going like, what happened? And that's the key. So I'm going to see if I can figure out what next is. I usually do this talk with one of my partners, and he unfortunately couldn't make it, so you'll see his name on a couple things, but I am maybe not. Did it move? Oh, there you go. So this is a quick example. Some of these slides go pretty quickly. Again, don't let that surprise you. They tend to be very duplicative in terms of the topic, but the goal for the next few minutes, what they allow us, is going to be basically imaging. And it's basically what has happened in medical care in the last many decades to really shift how we've taken care of patients in a larger way, and most of that's going to translate into different tests that all of you are familiar with in terms of x-rays, CTs, MRIs, et cetera. And we're going to touch on some of the differences and try to give you a little bit of insight into why one test may be chosen over another at any particular time and why we're doing all of this. But in general, this slide is just to indicate we've been looking in the body for quite some time. This goes back to the Renaissance, and we've been struggling to sort of do more, and obviously imaging in the last 100 years is basically due to this guy. Does anyone know who this is? This is Wilhelm Röntgen, and this is a German who actually sat down and won the first Nobel Prize that was ever handed out for the discovery of X-rays. And this is a cartoon example of his lab where he actually had this new device on the left where it was actually producing what was not known at the time, but later called X-rays. And he discovered that it was sort of impacting and interfering the screen on the other side of his lab. And he kept saying, why is it glowing? What's happening? Something's going on between this funny box and this screen. And he's the one who actually sat down and produced the very first X-ray. And this is it. This is actually Wilhelm Röntgen's wife's hand. It's her right hand, because in Europe they put their wedding ring on the other hand, as we do here in America. And this is done about 110 years ago at this point. I'm losing track, maybe plus minus a year. But this actually is the very first X-ray because they were able to look inside the body, which had never been able to be done before. And then they quickly developed other equipment. This is a very early X-ray experience where you'd sit down and actually have the X-ray tube bulb device here behind the patient, this fluorescent screen in front, and you would, as the radiologist, or who became a radiologist, they hadn't been named yet, would be looking at the front and watching these images as they go by, of course getting exposed and everybody getting exposed. We'll talk about that in a minute. Our equipment has gotten so much better, obviously. 100 years later, this is an example of where we have a technologist, and these are known as radiology techs, not radiologists. We'll get into that if you need to. We have absolutely phenomenal equipment that limits scatter and excess X-rays, so the exposure rates are a fraction of what they used to be, and we are very much every day trying to develop new technology, new advances that minimize exposure to patients, and we're going to touch on that towards the end of my talk as well. So different types of images, it's totally a word pool. Not unlike alphabet soup, we're going to have X-rays, CTs, CAT scans. CTs and CAT scans are the same thing for those who don't know. PET scans and MRIs, and we're going to touch on all of them and some of the differences between them. It's totally a word jumble, but what is it? Really, it's about the Wizard of Oz and what's behind the screen and who's the doctor. That person, that's the radiologist behind the curtain, and I'm going to basically expose them for you, all right? And anybody who's a little bit of a certain age remembers, obviously, Superman and the whole idea of X-ray vision. This was something that certainly has been discussed and described over the last 100 years. Very first 20 plus years of radioactive materials. Everyone thought it was the next breakthrough. People were taking it like morning tonics and discovering, oh, it's not so good for you after all. But we were going to obviously discuss now really what we're doing, and everything in sort of the next many slides is going to be discussing really the last 50 years. So once we got through sort of some of the early breaks, we learned how to harness it, and we're going to start with X-rays because that's really the beginning of imaging. So a little bit of physics I'm going to try to speed through, and I do apologize if I go a little bit fast. Again, I expect a hand in the air if it's uncomfortable because we're trying to make up a little bit of time here. But overall, radiation comes in numerous different wavelengths. And so you'll hear that term occasionally, and depending on the wavelength, determines whether it's really harmful, not harmful, and what it can achieve and accomplish. And so the next four slides are going to be just talking about different types of wavelengths. And I think you can, you can understand and see that the narrow band in the middle right here, that's visible light. That's what we see around us every day. It's what our eyes and our brain are able to detect and evaluate, and that lighthouse is sort of to represent that. Radio waves are way down at the bottom. These are long, slow radio waves, and we will then talk about microwaves, which we all heat up our coffee with, and they're actually longer than light waves. But what we're also going to be dealing with as we jump over infrared, TV remote, is X-rays. And X-rays are shorter, higher energy waves, and gamma rays are the things that Superman in theory and stuff that comes from outer space. So these are the ones that cause damage to our cells, and what we're going to be really focusing on in terms of imaging. So a little bit of physics here, and hopefully again this should be more fun. This is a little bit of comic relief, but okay, I've got an X-ray source that's represented by this little square box on the left. It produces X-rays that are sort of being shot through what this looks like. A Christmas cookie, right? Everyone should recognize that as one of those overly baked Christmas cookies we produce for our parents at some point if you have Christmas in your life. And you put a film here, and actually what do you get? And this is what you get, right? This is an X-ray of what? There's the Christmas cookie. And actually, just to finish it up, that's your Christmas cookie, but that's the patient. This actually wasn't a human. This was actually a dog that actually had sat down and wolfed down the cookie without even chewing it. It helped it shape. And the reason I use this as an example is because I think it captures the basic concept. You've got X-rays that are shooting through the patient, and if more X-rays hit the film that's on the other side, or a digital reader, which is what more modern, what happens is you get blackness. So here on the outer edges, all of the X-rays expose the film. And where there's less X-rays, where there's bone, because it absorbed a lot of the X-rays, or in this case, the Christmas cookie, because it was old, hard, and stale, actually it was dense enough to absorb some of the X-rays. It creates a shadow and an outline, right? That makes sense? All right. So what we're doing is, as radiologists, we're doing this on a large, fancy scale. And so in the next many slides, you're going to hear me talking about that as an example. But we as radiologists interpreting studies, that's the trick, right? We want to basically produce images and or studies that actually allow us to detect normal from abnormal, right? Something that belongs or doesn't belong. And that's going to be the real trick and basic fundamental premise of a radiologist's job. This is what? Anybody, obviously, there you go. So I've got some parents and grandparents in the room. They can't get away from this. Every child who has this loves it, right? And if you ever have a child with a Waldo book or Goldbug or some of the other variants, they are what? Insanely fast, right? You put the book in front of it, like, there it is. And you're like, what? I don't even know what page we're on. You, especially when you're older or not used to it, aren't very good at it. But that's another example of what a radiologist is. A radiologist is trained to identify where's Waldo really fast. And even though we can look through the distractions and the clutter, and we know what to look for. We know that he has striped shirts, he's got glasses, he's got a hat, whatever. And we just sort of, whoop, there he is. And you just get good at it. Now, we want to produce images that allow us to do this. So back to the shadow example. All right, so these light bulbs are basically to represent X-ray sources as an example. And if you're shooting X-rays through this three-dimensional person, and in this case, she is standing obviously with her arms out or with holding different pieces of fruit, depending on the direction of the X-rays, right? The shadow that actually is generated will identify, say, the pineapple, but you can't see the banana, and vice versa in the other direction. So this is my way of explaining to the group that radiology isn't just a single image. It's not just black and white, one shot. We often have to do numerous tests or many pictures within the same test to help three-dimensionalize and understand what we're looking at. So we're able to, in our mind, say, this is normal and this is abnormal. Is everyone tracking so far? Am I going too quickly? Great, all right. Am I going too slow? Maybe too. All right, so this is a standard chest radiograph, 2 views, standard. So when you sit there, you're like, why are they taking a second view? I'm too tired. Well, we want that second view because one view really isn't enough. It's always one view is no views in our mantra. We always want at least 2 views, or preferably CTs and PET scans, and we'll talk about those in a minute. But in this particular case, we're going to talk about different densities. I'm going to try to speed through this a little bit because it's not really super important, but there are 5 main groupings of densities on this image. And that means they're clustered information that we have to deter. We talked about how air is black because there's nothing absorbing the x-rays. It just shoots all the way through the patient, hits the film, and there's an example of the lungs, and there's very little information and very little body tissue for x-rays to be absorbed, as opposed to fat, soft tissue, bone, and metal being the marker up here where almost all the x-rays are absorbed. So all of our information is going to be designated as one of these 5 different categories on a chest x-ray. All right? And it's the difference between one group relative to the other that it gives us edges, contours, and shapes. And that's what's going to let us say abnormal, normal. And this is where we get really good. So now we'll go back to another fun thing. Okay, group, what is this? Everyone, or at least many of you knew that, right? There was no debate. Why? You recognize it. That's a great answer, honestly. I know what it is. Well, that's the same thing, right? We know what the heart, we know what the brain, we know what these things look like when you're really good at it and you have lots of years of experience. So you want somebody who's really good at it as opposed to somebody who's just sort of getting used to it. But in general, this baseball bat, there are lots of additional pieces of information. You're using the shape, you're using the density towards the end. You know that it tapers towards the handle. If you actually look carefully, it gets thinner towards the edge, so you can sense that it's fatter and it's round, right, because of the density differences. You can actually see the grain of the wood running through it if you really sort of get your nose into it. And all this information are examples of what we do with radiology and images to also help interpret. So we're actually using more than what you might see initially. And for those who are actually baseball fans and Chicago, this was actually one of Sammy Sosa's bats. If you remember correctly, and somebody just groaned, there was an incident where he had a corked bat. And so guess who got called? I got called and imaged all of his bats at 3 a.m. with a CT scanner to make sure that they weren't corked, which of course none of them were, we all knew that. And we just they gave me new bats. I'm sure they weren't the ones they was using, who knows? But that was bat number 4. So I use it as an example. So CT scans is really where I want to spend a little more time because that's what you're getting done predominantly. And CAT scans or CT scans, again, synonymous terms, is basically x-rays and x-ray images, so like the one you see here on the left, turned into slices and images that are very, very numerous. And we're going to be looking at the whole body somewhat like a loaf of bread, and I'm going to go into a couple examples. All right, so how does this done? It's numerous slices, and when I was much younger and starting out, our CT scanners were super slow, and it would take 5 seconds to get each picture, and they had to hold their breath. And now we can do the entire body top to toe in less than just 3 or 4 seconds. The scanners and our equipment has transformed immensely over the last several decades, and it's incredible what we're able to do and reconstruct, et cetera. And we'll give you some examples. But overall, what we're doing is we're 3-dimensionalizing the body tissues when the prior examples in the x-ray, which I showed you, is 2-dimensional, right? It's flattened, everything superimposed on each other. You get good at differentiating something that may be on top versus something that's separate. CT helps us say, oh no, there's a little tiny dot in here that was overlapped by a rib and we didn't see it on the other. And it gets a much more sensitivity and what we call accuracy in terms of our imaging. The way that works is that we actually, inside the machine, there's an x-ray source, there's a huge donut of detectors, and actuality, there's an arc of detectors, and sometimes you'll hear them say it's a 240, whatever, that number you hear after the scanner is the number of detectors. And what it is it's spinning very fast, and that's what allows us to do imaging of a patient as the table moves like a corkscrew. They're going through and they're getting pictures, thousands and thousands every nanosecond, and we reconstruct all those images into pictures. All right, so back to our bat. I know I'm jumping back and forth. Basically, we cut through the bat. If it's 3-dimensional, right, we know it's going to be round, right, because the bat is round. Same with if it's cut obliquely versus length, etc. These are things that we are doing in our head when we're interpreting chest x-rays and chest CTs. In this particular case, I take with my students, I actually took a treasure box, put it into the CT scanner with a whole bunch of stuff from my desk, my secretaries, et cetera, and I ran it through the scanner. And for many years, before they outlawed it, I would bring a bottle of wine to my medical students and say, okay, everyone, you've got 24 hours, make a list of everything you can identify in this scan. And it was a great sort of fun game, but in reality for them, they actually sat down and had to start to identify different items. And you can identify one too. If I sat down and said, where's the slinky? Where would you say the slinky was? Which quadrant? B, very good. You know what a slinky looks like. It's metal and it has a shape, and we'll get into that another point. So we basically will slice up scanners, slice up images like a bread loaf, and we can look at things. You can see like a vase with a potpourri and a pine cone. That was off my secretary's desk. And then we could also look at different things like, ooh, there's that, and change the shape and or direction. We can reformat images. That's manipulating them after the fact, and there's a cat, hence it's a CAT scan. That's a joke, you're supposed to laugh. But that's what we're doing in reality. Now notice only the first time, this is the first patient I'm actually showing you. This is mesothelioma. And the reason I wanted to go through those first many slides is to sort of really launch you into thinking of how we look at the images as opposed to just looking at them and saying, yes, no, black, white, here's a number. It's not that simple. There's an art to interpreting scans. It will be different. I will look at the same scan a week apart, and whether I had coffee in that morning or had a fight with my mother that night or whatever, it can interpret. It can infect your interpretation. Obviously, those are really good, and those who are more experienced, there's a lot less of that. You know how to manage yourself, and you stop working. I mean, I know radiologists that say, not today, I need an hour, I'm gone. I need to go work out. And we learn how to optimize our interpretation skills. And that's one of the main reasons why radiologists are really the best at this, because we train ourselves, we actually study not only how to make great images, which we do, interpret great images, which we do, but we actually are studying how the brain actually interprets the dots and the data that your eyes are actually sending to your brain. It's all part of our field in terms of trying to optimize and not become victim of bias and other things that we know how to bypass because we've trained ourselves to. That makes sense? So in this case, image like the whole body here, we look at it axially, that's cross-cut. We look at it cut like vertically and from the side, and these are called axial, coronal, and sagittal images. Don't let those terms bother you. Just know that we're looking at things and three-dimensionalizing what is a very, very complex, difficult tumor. And that's what makes meso so special, a very misused term, but the bottom line is most tumors, especially like lung cancer, there'll be a dot, a small focus that grows. It grows like into a small blueberry, into a cherry, into a walnut, right? It just grows out bigger, might be up against something, but it's round and it has sort of that shape. Mesothelioma is thin and filmy at first. It grows in predominantly, if it's pleural mesothelioma, it's thin and it grows in the space around the lung and the lining of it. And so as it grows and expands, it gets thicker and lumpy, but it can go up and down, and it sort of hides against all these other structures that can be very hard to follow and track, and hence why we really specialize our efforts in terms of interpreting them, and we'll go into that as well. But these red arrows of the next three slides are actually identifying areas of tumor as opposed to fluid and effusions and other things that can grow into the chest wall, it can grow into the bones, it will grow through the diaphragm here, and invade other compartments within the body, and all these things are part of what we're looking for and trained to look for on a continuous serial basis. And that's another reason why you tend to get scans. I have a feeling I'm talking to an audience that knows your scan every 6 weeks, every 2 weeks, or 2 months or whatever, you got a timing, stick to it, because it's those serial images that are equally important for us to detect, not just a single example and not a single study. All right. The other thing that's also really helpful is get it done at the best possible place. That may not be the place next door or the most convenient. You want to have your scans preferably done by the place, in the same place, so they have them, all the images, and they are doing the same routine over and over. They're much more likely to pick up stuff as they go forward. So we'll get questions in a minute. So as we're going through report, I'll just be really fast. We compartmentalize our reports. I think it's pretty self-explanatory. It helps our doctors, both interpretation and in terms of our referring physicians, to fully appreciate and find the information as they need to. So you'll see different things in different sections. Though that shouldn't scare you, but it should also be something you see. If you see a report that does not have sectioned and or reports that have been optimized in a structured way. Find me, I want to know where this is, because get your scans with me or something, get your scans with somebody else. This is standard practice in this day and age. Positron, I'm going to jump a little bit towards PET imaging next. Anyone had PET scans at this point? A couple? Okay. Yeah, there you go. What's different about PET scanning? X-rays we talked about, CTs, which are a form of X-rays, just done with lots of computers and lots of images. PET scanning is where we actually are injecting you, and those in the room know, with radioactive glucose. And that actually circulates through the body. We image you a period later, usually about 1 or 2 hours later, as it goes around to the different tissues. And we've discovered that this glucose goes to tumors along with infections and a lot of other things. It's not very specific, but it goes to tissues that are chewing through glucose very fast. And that tends to be an air mark and quality of tumors versus regular tissues. So it helps us identify really subtle areas where we might not have otherwise been able to see it on, say, a chest or abdomen CT in particular. So these are examples of PET scanning and lymph nodes that are sort of outside the field and looking at the whole body. PET scans basically then are a form of imaging function as opposed to the form and the shapes of the organs and the tissues. And that's why it can be really special. PET scans are technically is just looking at those little dots, and that's actually the scan, but you're used to the one I just showed you with the orange on it. Those are actually combined images with a CT that's done in combination with the PET scan simultaneously, and we merge and overlay the images on top of each other so that we have the benefit of the CAT scan knowledge, i.e. the bones and the heart and the solid organs. So when we see, in this case, an orange dot, we can say here it is relative to these other structures. All right, but technically the PET scan is the orange only, not with the other stuff. And so you have to have, again, good quality scanning equipment that allows you to do that sort of thing. This is an example of a glucose. We just replace it with radioactive fluorine, and most importantly, and we'll get into the physics, why it works. So I can get into it if anyone has a question. MRI is the other thing you might have had done that's certainly a more advanced, that really came on board about 30 some years ago. It's actually where we use magnetic qualities of tissues. Okay, every atom, every structure in your body is made up of atoms, and those atoms have a polarity to them. And if we put you into a huge magnet, and that's what an MRI is basically a big magnet, and this is to pretend to be a magnet here. What we're doing is we're taking all of those atoms in your body and we're putting them into a single direction. It forces them to line up with the polarity of the magnet. And then when we turn it off or change the strengths of the magnet, we're getting to so that it's sort of beyond this particular talk. But what happens is the atom itself goes what we call rings down and goes back to its standard state. And that change from polarized into single direction to standard normal state is called ring down. And actually, because we listen to it, we have very special antenna, essentially, that are in these MRI scanners as they're ringing down like bells or like bottles that you would sit there and look at, and we're able to turn those into images. And it's extremely good and effective at looking at soft tissues. It's not good at looking at bone. It's not really great at fat and a few other things, but looking at things like the brain and the muscles and the soft tissues, which you remember on the X-rays and on the CT, they all sort of looked like the same blurry level of gray. There was not a lot of differentiation in those tissues, and this is our way of looking at really good differentiation of soft tissues. And in this particular case, that's a side shot of a brain. Here's the back of the brain, spinal cord. These are the vertebrae with bone marrow. And here's an example of a tumor that's growing and started within a vertebral body, growing out. And MRI is just the best way for us to capture where's it going, what tissues is it impacting. In this particular case, you can see it engulfing and disrupting the nerves that are coming off of the spinal cord that were feeding the person's lower chest and the like, and it counted for symptoms, et cetera. And this is, again, what we're doing. We're often taking the patient's presentation, we're doing imaging, trying to find a cause and underlying result, but more importantly, we're tracking and able to look at these scans over a period of time so we can actually make sure that we give the physician, the referring physician, quality information to say, not only this is what it is, here's a diagnosis or potential series or short list of diagnoses, but more importantly, is your treatment working and where the patient is going from then on. Tumor response is actually then the next step. And how am I on time? I'm doing well. Okay, good. Oh no, I heard that. Thank you. I got my hand signal. We're getting nearing the end. All right. The tumor response then is really the big issue with you guys, is that we're actually trying to really evaluate the size with CT and the response and change over time. So the serial images, hence being done at the same institution time and time again for consistency and clarity, is really going to be key. All right, we'll talk about different protocols and response criteria. It varies tremendously if you're on special protocols, special research projects, or depending on who your physicians are. But on the whole, the concept is the same. We're just looking for differences as over time. We look at and measure different tissues. I'm going to jump over this, but it's really, for mesothelioma in particular, thickness at 6 different locations. We're actually going to be adjusting this very soon. We have a paper coming out, also in the 9th version. We're always trying to revise our imaging characteristics so that we're able to track across the entire country and world in a similar fashion, so we can actually use data and combine data for research purposes. And you're going to be hearing about that hopefully in about a year. Response then basically gets 30 or 20%. You might hear these numbers when you talk to your oncologist, but we're just looking for progression, stability, or the like. And these graphs are just identifying that. You'll hear about different numbers. Different drugs have different potential, and you'll hear that mostly from your oncologist. We use contrast in particular to help make our images more sensitive to actually subtly looking at edges, so we can actually get more accurate measurements scan to scan. So if they sit there and say, please let us do an IV, and you have no contrast allergies or kidney problems to prevent it, the answer is yes. I know it's an IV, it hurts, it's not fun, but it really makes something that's blurry, fuzzy into something much sharper and distinctive, and we're more likely to find things like lymph nodes and other smaller areas of involvement which we might not otherwise have seen. Radiation exposure, my last 3 slides, and I just wanted to touch on that because I sort of drill down to one of my most commonly asked questions, and that is, I get all these scans, am I just making things worse? Okay, and I want to reassure everybody in the audience, the answer is no, not likely. What we have in front of you is a graph. The image on, the axis on your right, this is the risk of cancer, essentially, i.e. the likelihood of developing a cancer with exposure of radiation versus age, which is across the bottom. And if you actually look, if we expose babies and young children and teenagers to high levels of radiation, the risk of disease is much higher, by the way, for women than it is for men. But as you age, and especially when you start getting towards 50 and onward, that risk is just nominal. We're talking just 1-2%. I mean, it's not much. And the risk of developing a complicating issue related to the radiation is just minuscule compared to all the benefits that you're actually going to get from the imaging. So it's a trade-off. Nothing's perfect. But in this particular case, we're all at this end of the scale. We're not at this end. So keep your babies and young women, and especially your teenage girls, out of the scanners. But that has to do on the difference, by the way, between men and women is almost entirely breast tissue. Breast tissue is very sensitive to radiation relative to other body parts. So that's the piece we need to keep out and try not to scan. So that's us at that end of the scanner. This is my I always love The Simpsons. But basically, a couple examples in terms of how much radiation you're actually getting with a CT scan. I would sit there and I just want you to know, natural background is living your life, right? And it's worse than if you lived in Colorado than if you lived in, say, Massachusetts. Actually, places with mountains tend to have more radon and other things that are coming out of the dirt. But on the whole, the amount of background varies a little bit, but you can see it's not that different. And I just give you a couple of examples. Smoking cigarettes. I mean, literally just a few cigarettes a day is more than equivalent to a scanner. Or flying to literally not even to another continent, just talking across the country is basically the equivalent of a scan. And we do that every day without thinking about it. So here's some examples, and I always like 40 tablespoons of peanut butter. Who has not eaten 40 tablespoons of peanut butter? But that essentially is, you're exposing yourself to radiation, but people don't think about it, all right? I'm just trying to give you some ideas that the imaging source of radiation is relatively small. So on that, I hope we're getting a little bit closer on schedule, but I definitely want to entertain some questions because I have a feeling I've generated a few.
We can take a couple of questions.
Yeah, and let's start on this end because I've been very unfair to you guys. Okay?
And you can feel free to stand up if it's more comfortable.
I have a question about PET scans and like previous pleurodesis. So like a 30 years ago pleurodesis, and then that lighting up on a PET scan for meso. So would you recommend like tracking everything through CT, or would you go with the PET scans?
I would basically probably a combination. I wouldn't say that it's all one or the other. You're going to be followed with CT, invariably, because it's easiest, it's relatively simplest, it's not as involved. PET scan will certainly give you a certain amount of confidence that there's nothing hiding potentially in a lot of scar tissue, depending on the pleurodesis. Some leave you you look sort of like the way you started, and others you look like someone's been in there and mucking around. And so those can be a little bit harder to be confident there isn't something lurking in a corner, and the PET scan may help you there. But overall, it's really going to come down to serial imaging and looking for change over time.
Okay.
Great question. There's one more right next to you.
One more?
Yeah. And I'll stick around a little bit after if need be.
With the amount of data you're looking at with all these scans, how much of a role is artificial intelligence playing looking at this?
I should have assumed I was going to get this one. The answer there is AI is our friend. Radiologists have been using AI. I started working with the first AI program 30 years ago. We actually invented it at the University of Chicago. It's the top breast imaging it's now a company that actually can go off and assist us to be more sensitive and more accurate in our performance in doing screeners. So it's not something to be scared of. It will not replace us. There is so much complexity, and I think the average use of AI and the way you see it in social media and stuff, obviously it has a huge play, but when it comes to medicine, it's just amplified 10 times, and we're using it as a tool to make the radiologist more effective, efficient, and basically get through what used to be 10 images in an hour. Now we're actually having to look at 1,000 images in the same amount of time as 20 years ago. We have so much data to look at because our equipment has gotten so much better and fancier, and we're doing more studies. But we, as the number of radiologists, obviously stayed pretty similar. And AI is going to be a help. It's going to be the next real advancement in the next 10 years in allowing us to become and maintain our effectiveness as interpreters. If that's sort of a quick answer.
Okay, one more, but really have to.
I'll catch you later.
Will be available after as well.
How often do you factor in the volume rather than a slice?
That's a great question, and again, the whole room, I'm sure you've now heard imaging, volume versus non-volume. And there is a big debate over really what is most accurate. And I will say that on the whole, you are talking with somebody at one end of the spectrum. I have to identify, I'm not a pro-volume or anti-volume. I'm just saying it's not the answer or end-all be-all. I want to re-emphasize what I feel, and again, this is me, needs to be discussed is change from scan A to scan B, or baseline through a series of protocols. Is it working? Is it not working? That's really what your oncologist needs. The actual volume, and people get hung up on it for a good reason, because there's some earlier studies that showed this treatment was effective when it's under 500 milliliters versus if it's bigger or more, et cetera. And surgeons, of course, like to quantify. It's part of their job. But in reality, it probably isn't. There isn't this stern cutoff. It's like, we had 550. Are you in a different category? The answer is no. It's really a question of identifying more, as we go forward, genetics. Where is it located? Are critical structures involved, et cetera? Can we do a surgical intervention, whether it's palliative, curative, or whatever? I mean, those are all sort of variants in the same scheme. But what can be given systemically, if we're at that stage, which not infrequently you are with meso, and will it be effective? And getting you targeted into the right category, which I know is Hetty Kindler's talking, several talks you've already had, right? Immunotherapy versus other, et cetera. But from an imaging perspective, it's really about change, no change. Can I, at the earliest possible time, maybe even 3 weeks later, is this working? Keep giving it. And obviously, hopefully you don't have repercussions or complications related to it, but stay on course. Or no change, and if we don't, we've proven that that's you need to switch to something else, right? We got 3 other choices. Let's use the other one. The key is to individualize the care, not lump you into a broad category which you may or may not fit. Does that translate? Okay.
Thank you, Dr. Strauss. Applause, please.